everyone. Welcome back to It's a Lot, Let's Talk. I'm Kylie.
And I'm JP.
So, today we want to dive into the village of practitioners and people it takes to care for an individual and how each practitioner layer supports a healthy aging at home. Um, so, as we all know, it's not just one individual who cares for an older adult when maybe they need a little bit more support. It does truly take a whole village, whether that's a companion, a PSW, a RPN and RN, a family practitioner, or realistically on the day to day, the unpaid caregiver, that family. So, um, each layer has and serves a distinct purpose for what they bring and how they can support that older adult. But they are very different in each layer. But ideally, they don't overlap, but intertwine to some level so we can create this idea, or not idea, but this ideal healthy aging at home.
Yeah. And if we look at it from a couple of perspectives, one, if we look at it from the family's perspective, yeah, there's the unpaid caregiver, as you mentioned, and they're kind of thinking, okay, there's all these different types of practitioner roles. There's from companion to a nurse. Which one do I need? When do I need it, and so forth. So it can be kind of a complex, confusing kind of process. When do I plug in? Who do I plug in? So forth. And we know why, care coordinators come into play and they kind of help navigate and figure those things out. Not everybody can afford or has access to that, so that's a reality. And then the other kind of viewpoint is from the system itself in terms of what practitioners they employ in the process to help people age at home. And like you said, it starts at a companion, we'll call it at that level, which is non-medical typically, all the way up to, a registered nurse. And so it's
Mhm.
just kind of figuring out which one do you plug in? Um, do you need all of them? Do you need one of them? That's what we want to explore today. Like kind of make sense of that from the family and the senior perspective, but also from the system perspective. And are certain roles being utilized the way they should? Are they being underutilized? Where are we losing value because of these preconceived notions of what each of those levels bring? And I'm excited to kind of explore that with you because one, on the family's perspective, they may not have a clue, and on the system's perspective, they have these pre-notions of what things should be. And I hope in our conversation today we kind of challenge that and kind
Yeah.
of look for different ways. And I know, from your research, I'm excited to hear from you on that perspective in terms of, what contributions are they supposed to make and what are they actually making? And does
Hmm.
that kind of does the purpose meet the reality?
Hmm. And I mean, I guess if we want to start breaking down the layers, the reality is the first sort of layer of support in a ideal situation, or not necessarily ideal, but if the senior or the older adult has a healthy family support system, the first layer of that support is always going to be the unpaid caregiver. And we've talked a lot about the unpaid caregiver and what that looks like and the burnout that can come from that. So the next sort of layer that, and I'll speak in sort of a level of least clinical to most clinical. So the if the older adult is sort of have is does have a healthy aging process and maybe is a little less clinical and needs just a bit more social support, and then we'll discuss through um, sort of more some complex needs that could be required. So the first layer would be a companion, and that would be for some early awareness and social stability and very much non-clinical support. So maybe this companion comes into the home to provide respite care for that unpaid caregiver so they can step away and go get groceries or get their nails done or their hair, whatever it is, take a moment for themselves. Because truly, as we've discussed, an unpaid caregiver is a very, very difficult, time consuming, guilt-inducing job that they provide. Um, so a companion can also just be for social interaction. There is an issue right now, specifically with older men and social isolation, and so a companion coming in just to chat, to sort of talk about old stories, reminisce a little bit, play some games, just sort of uh, provide a friend almost, someone you can chat with. And really what this companion is at the core is sort of some early observation of change, right? And again, non-clinical, but supporting their daily living. And the more that this companion gets to know the older adult that they're talking with, the more they're going to notice as time goes on of their mood changes, their routine changes, some mobility, and sort of if they need to escalate that at any time, obviously they would have to then go into the PSW. But for
Right.
the companion, it's very non-clinical, very I'm your friend. Let's do some daily activities together, maybe some meal prep. It's very ideal for early stage support and prevention.
Right. And unlike the other layers, like the PSW and the nurse kind of layer, um, there's no formal training for a companion.
Right.
One could argue that, anybody can do it, but I know the work that you and I do, we don't necessarily agree with that. Not that it's necessary or required, I should say, but it's important that companions are trained to some degree, whether it
Right.
be um, being able to kind of think about what's going on in the relationship that they're having with that senior, or if something were to break down, what they could do and so forth. What are your thoughts on that in terms of type of training that potentially could be provided to a companion that could be helpful in that whole, aging out?
Yeah. I think that training is always crucial. You should not send a companion into someone's home blind by any means because you could be walking into a lot of different scenarios each day. And that's why a lot of PSWs do provide that companionship because PSWs do have training on um, safety in the home, or they have extensive training on obviously personal care, but they also have that layer of companionship that they are trained on. And I do think that's really important. And if there was sort of a standardized training program for companionship, I think that would be very beneficial for not only cost-effective reasons, but for the client, but also for early stage prevention and stabilization before a crisis or before a PSW would be necessary. So I think it would be crucial. There is no standard training at this time that I'm aware of. But again, a lot of PSWs or personal support workers do provide that companionship, whether they provide it at the cost or the pay rate of a companion versus a PSW. I'm not necessarily sure. I'm sure the pay rates are different, but
Yeah.
a lot of
And
PSWs.
Yeah,
Yeah, go
and of
ahead.
course, economic reality, a companion is not going to be um, as costly as say a PSW. A PSW is not going to be as costly as you go up the chain.
Exactly.
And I will say, and obviously, at Cardera, we're always thinking about how can we leverage each type of position so that it can add value to the senior, but add value to the families as well. And
Mhm.
when we've talked about and we've developed tools around early detection, like you just said, in terms of, they're the eyes and the ears at the entry point where they're just starting to develop a relationship with the senior, and to ignore that opportunity I think is where the system breaks down,
Yep.
by utilizing an individual who is perhaps with them, developing that relationship, can try to see the good days, the bad days. We're not asking for assessment, we're not asking for diagnosis, just observation and,
Right.
and being able to frame those observations in a way that kind of goes up that chain, that layer, all the way up. Can help with the process. And that's what you said at the beginning, it takes a village, or it's not just a one-time isolated event, it's a continuum. And if it's a continuum, how do we leverage each part of that continuum so that we get the most out of it? And with a companion, non-medical, can't make assessments, can't make diagnosis. We all have opinions, but they're trained to not do that, but to observe and to report back on those observations. And I'd love for you to just talk about or give your sense about, what sort of frameworks. I know Cardera has put frameworks in place, but just generally speaking, not talking about ours specifically, how does a framework kind of help a practitioner identify things that they should flag or that they should not even flag, because flag's too strong of a word, but that can report back and say, hey, I observed this or that. What sort of framework do you think needs to be in place around that?
Yeah, I think on a companion level is different than a PSW. And well, yeah, I think so because PSWs are trained in personal care as well. So I think the structured framework could be different, but I'll speak generally as one framework and maybe I'll speak on the PSW level. But I think it's important because a PSW in was designed to be a taskmaster. They were designed to help the nurses in personal care so they could sort of focus on this clinical aspect of IVs, everything more clinical than sort of the hygiene or the mobility and the feeding and things like that. So when a personal support worker, they are the most, and maybe a companion as well, they are the most high touch point. They are with the client the most, but their opinion is undervalued the most, which is funny to me because they're with them all the time. Why are we not utilizing their observations, what they see in the home or community, what they're seeing? So, if we could put together an ideal framework for the PSW, maybe it would allow them to be respected more, their observations. So, what that could look like is standardizing what they're looking for or what sort of is happening in the home, I guess you could say. Because realistically, the PSW is with the older adult. Let's say they're with them every day for months. And a nurse comes in for an assessment once a month, once every 2 months, maybe even only as necessary. That PSW is going to know that nurse, or sorry, the PSW is going to know the client, the older adult, way better than the nurse coming in because they know their everyday actions. They know what their routines are and how they react to certain conversations or actions, whatever it may be. So, an ideal framework would be something formal in place, asking the right questions on maybe behavior, cognitive changes, physical changes, things like that for the PSW to look out for, to then sort of have a formal, I mean, a formal structured framework, I guess, point blank, for the nurse to then use when maybe a red flag is raised, or maybe there's still a green flag and the client is still doing well and nothing to be concerned about, so no escalation is necessary.
Hmm. Absolutely. And you talk about observation. Observation and isolation, meaning one person observing, can be flawed or it can't be flawed. I see something happening, I can report it on. And that's all it is. And I think when it
Mm,
comes to training is making sure that there's a difference or they understand a difference, whether it's a companion or even a PSW for that matter. They understand the
mhm.
difference between observing and giving their opinion. And and
Right.
and the training is kind of really clearly identifying that, and the framework you're suggesting, helps them stay on focus, right? And so I can observe something and report on that versus I observe something and I give my opinion on what I actually observed. We're not talking
Yeah.
at that level. We're just talking, I know, the last time, I met with this individual, they seemed to have a strong gait. This time they seem to be wavering kind of back and forth. It's an observation. It's not coming to a conclusion. It's observing. And you can be trained on that. And that can be valuable data, that could be valuable information that could be passed on up the chain so that, things can start to figure out what's going on. And
Hmm.
companion is non-medical. Companion will never necessarily bathe, the client or the senior. That's more of a PSW role. But
Right.
a companion is with them, like you said, and observes and could pass that information on to the PSW so that maybe when they are bathing them, they can look out for this type of thing. And again, a PSW is not making, like you said, assessment or diagnoses. They are with them a lot. They're observing. And I look at it as at least within Cardera, I look at it as those are observational points that are kind of gathering this set of information that in isolation may not mean anything, but over time, if you start to identify patterns and themes, whether it be through a manual process or using technology or whatever, could start to help figure out at least what direction that individual is going in. And if we know what direction the individual is going in, you can adjust care accordingly. And I think that's the important. Now you said something interesting about PSW. They're under the you had high touch point, but underutilized. Talk a bit more about that. Like, the reality is I agree with you. They were masters. There's an economic kind of relief in using them because they're not as costly perhaps as a
Right.
nurse. Go into more about like high frequency of contact but low usage or low utility.
Yeah, so the high frequency is obviously being in someone's home more often than a nurse. Maybe not more often than the unpaid caregiver, but if you have a PSW, like I said, in every day, obviously that's a high frequency, high touch point with the client. They build relationships, they build connections. They the client expects that PSW to show up and understand what they're going through and and humanize them. They're not just a they're not just a subject for a nurse to assess and then be a statistic on a chart or have this happen or that happen, whatever it may be. So the PSW is really in there almost to humanize the individual, the older adult. And when it comes to then like so them being the most building the best relationship, I would say, with this older adult or the client, they can sort of have this skewed observation versus opinion, as you were talking about, because they know this client so well. So oftentimes, if then they're reporting that, say, like you mentioned, there was a little bit of wobble in their gait today. Um, there's so many different ways they could say that could come off as opinion when reality is it's an observation. And sometimes, and I don't want to generalize and say all the time, but sometimes when reported gets skewed into, oh, well, that's their opinion, that's not a fact, there's no need for escalation, or that's their opinion, that's a fact, there's need for escalation. So oftentimes their observations get turned into or misconstrued as opinions, and then they become undervalued, and their now opinions, which are observations, are not taken seriously, which can be a huge issue for the older adult if they did need escalation, or even if they didn't need escalation and they end up at the hospital for no reason, which is
So if I read in my report, I'm a nurse, and it's just a PSW. Well, why are they making these opinions or these
yeah,
assessments? That's not their job. That's not their role. Versus the language they use in reporting that, saying, "I observed this. I'm not making any conclusions from. I just observed this." Hence your framework you were talking.
right. And here's the thing, like we've said, the PSW was put in place to be a taskmaster. They're there to do personal care. They're not there for clinical reasons. So when a nurse looks at a PSW and says, "Oh, you have this observation or this fact," like what do you know? You're not trained on that. And
Mhm, mhm,
the system designed it to be that way, truly, because they were
mhm.
put in place to do tasks. And at a more cost effective or in a more cost effective way. So the system is built to almost not appreciate the PSW's opinions or observations, yet they're expected to do so much for the client.
Right. Absolutely. Yeah, and the system, I think the system, how it's set up conceptually makes sense. But like in any system, when you add that human element, it starts to get distorted and moves away from what the system was intended to do in the first place. And when you have a PSW report opinion and an RN kind of, or an RPN, and again, we're not generalizing, we're just saying, talking conceptually. If they interpret it the wrong way, the system breaks down because they,
Mhm.
instead of saying, well, what they really wanted to say is, they wanted to share their observation, but they're sharing their opinion instead of just recognizing that and say, yeah, this is just an observation. I could still use this data. Maybe I ignore the opinion, but I use the observation. They ignore all of it.
Right.
And that's where it breaks down versus a system. If it was in a perfect format, there would be a framework like you were talking about that would minimize, again, we're dealing with humans and we're all flawed, we know that, would minimize opinion and focus on observation. So when interpreted up the line from an RPN or an RN, or even a doctor for that matter, they're able to see that, yeah, yeah, it's just an observation. What can
Mhm.
I do with that observation to make a determinant in terms of next steps or what I need to do, et cetera, et cetera. And I think, yeah, the system is let for argument's sake, let's say was constructed well, but the human nature of it breaks it down. And so
Right.
when you add another layer, like a framework to it, and observation kind of comes through, it may be able to help with that. So totally agree with you in our experiences, at Caldera. Um,
Yeah.
Starting out, I remember having these conversations with you and saying, how do we leverage, the folks that are going to have high frequency to kind of guide us towards delivering the best care we can. And that's why, coming up with frameworks, coming up with training, all of that is absolutely critical.
Absolutely. And we have put some frameworks together in Cardera so for the student companions and the PSWs if escalation was necessary, but we'll chat about that another day. We've kind
Right.
of gotten off topic a little bit of the layers of support systems in there. I feel like we have touched on the PSW level quite a bit, but the
Which
next
is
level
not which is
one.
not off though. I know you're saying in jest that we've kind of got a little off topic and we've talked to them a lot, but I think it's representative of the high frequency, right? That
Absolutely.
we're talking to them,
Yes,
talking about them, which is which
absolutely.
is which is interesting. But yeah, go on. Sorry, I thought that was
No, that's okay. No, I fully agree with you. I just in the sense of um underutilized. We didn't discuss what the PSW is actually in there for, which is daily living and hands-on support for personal care, monitoring physical changes. We touched on it briefly, but I'm just laying it out clearly for the flow. But
Mhm.
the next level obviously would then be RPN level and RN level, and they are very similar, and sometimes the lines for RPN RN get blurred. So I think um, I will speak on just a nurse level of sort of, I guess RPNs would be less complex. And again, I don't know, the lines are very blurred. But for sort of RPN, it may be more everything a nurse does, but maybe at a less comprehensive level. Um, Again, lines are blurred, so I don't want to speak too much on it in that regard. But an RPN may provide some more sort of medication administration, um, sort of the planning of medication as well. Obviously, a doctor is very necessary in that process. A nurse cannot provide or prescribe medication, but a RPN or RN can administer that medication, something that a PSW cannot do unless they are certified separately. Um, and then an RPN is also very good for health monitoring and assessments as well. Assessments maybe not as complex or comprehensive as that RN, but nonetheless an assessment that is taken very seriously. um, managing some chronic conditions. Both RPN and RNs are able to provide those supports for chronic conditions. Um, and very much responding to healthcare crises and statuses, um, and knowing when a hospitalization would be most necessary, and that comes through the assessments as well. Um, and then communicating all of the information they see in the community with physicians, families, even PSWs, and providing guidance to the PSWs in a clinical aspect because companion and PSW are not clinically trained.
Yeah, absolutely. And I'll give you a specific example of Cardera. Especially if a family's not sure on the level or the amount of care that we need, we send an RN in to do an assessment, and they
Yeah.
kind of help determine, what sort of care is recommended. Never forcing it, but sort of what's recommended. So if it's at a certain level, maybe you just work with an RPN, or if it's just daily living stuff, as you suggested, you work with a PSW, or if it's, minimize social isolation, you work with a companion. But yeah, we see the RN kind of coordinating the team, if you were, of
Mhm.
what's going on in the home and how things could be applied and so forth, and kind of making that initial assessment. We always recommend doing an initial assessment if we're seeing a senior or a client for the first time to kind of figure out where we're at from a physical, physiological, from a cognitive level, and
Yeah.
then apply appropriately. But it's a starting point. So, we can say in price there's a hierarchy, right? RN is more expensive than a PSW, sorry, a RPN than a PSW than a companion. But also in terms of the types of care, there's a hierarchy as well. But having that initial assessment from an RN kind of helps set the stage in terms of what's the plan, what's the approach, et cetera, et cetera. And we're not even talking beyond that, the geriatrician and all the
Right.
family physicians and all of that type of thing. But at the home care level, I know Cardera, that's where we're starting at. Let's do an assessment, figure things out. A lot of times families are coming in with an assessment already and we're using that. But again, it's a great starting point.
Yeah, absolutely. And those RNs really do provide that leadership in the team of coordinating and care planning and making adjustments when necessary. They truly are critical in home care. That's not to say
Oh,
through all of our conversation today, it's not to say that they're not critical or they're too critical of a PSW or they underutilize or undervalue them. They're an RN truly is the leadership, the core, we need them, right? Like
absolutely.
they support every aspect of home care
Yeah.
and
Yeah.
guidance.
Yeah, and my 2 cents is this. I think at every level, every layer, like we call it, for unpaid caregiver to companion to PSW all the way up to nurses, um, it's trying to get the most out of them. And training is obviously more involved at a nursing level because they're in school longer from a clinical perspective. But they're still on the soft side, dealing with patients and dealing with clients and so forth. At a companion and a PSW level, totally believe the system was set up in the correct way. The execution is perhaps lacking. And, providing a framework, like you said, providing their observations versus their opinions and recognizing the difference between that can add a lot of value to the whole process and the whole flow because it is a continuum. And if the continuum
Mhm.
breaks down, it stops. And so, how do you kind of keep that continuum flowing is providing that support, providing that framework, providing that ongoing training, and so forth. And that could be argued for unpaid caregivers as well, right? What sort
Yeah.
of resources? And we know there's a lot we've talked about in the past, a lot of resources out there and organizations who provide those resources to give as much information to the caregiver so that they can do as an effective job as possible because they're part of the continuum as well. Talk about frequency of contact, they may be way more than anybody else. So giving them those frameworks and those understandings is really key.
Exactly. And oftentimes, well, you would hope that the unpaid caregiver is taken seriously when they have this opinion or observation as well, right?
Yeah,
Because they're
absolutely.
maybe related, a friend, family, they had known them their entire lives. It's funny then when you throw a trained professional, a PSW, who does have those sort of soft skills and is put in there to humanize a little bit more. It's funny how then they're undervalued. So,
Absolutely.
I don't know. I
Yeah.
think the biggest thing is not providing more care, it's providing the right care and getting the right care in when necessary. And
Mm.
how all of these layers work together to avoid gaps and streamline the process to make it as easy as possible for the people who need care the most because it is overwhelming, it's daunting, it's hard to accept when you even need care as the individual, but as the family and the unpaid caregiver as well. So there's so many layers that need to work together in order for everything to go smoothly. And
Right.
it doesn't have to be figured out alone, but it has to be figured out
Right.
and it has to
Yeah.
run.
And I think if you look at the continuum, if you're, we recommend, that to all clients that are coming to use Cardera is do that assessment first, right?
Yeah.
Let's start with the RN coming in and saying, okay, this is what I see, this is what I recommend, and then go from there. Maybe, hey, you need a companion because of this, you need a PSW because of this, you need an RPN or an RN because of this, and
Yeah.
then figure it out. Or we encourage and part of our onboarding and training for our ends is to work with the caregiver and say, okay, this is where you need support, but this is where you could do things yourself, and this is what here are some suggestions on how to do that, and so forth. Start
Hmm.
with the assessment, but leverage all of the parts of the system, parts of the continuum, so that you get the best care possible for your loved
Exactly. And they can be costly, but they're there for a reason. And at the end of the day, an assessment is going to help you set up the best care plan possible and support the PSW, the family, the client, ultimately the client, in the best way possible. So I agree, the assessment is very important, and that is definitely a recommendation we would make at Cardera. But
one.
yeah,
Okay,
so I mean, I guess we'll wrap it up here. Thank you everyone for joining us today on It's a Lot, Let's Talk. We'll catch you next time.
take care.
Thanks for listening to this episode of It's a Lot, Let's Talk. If something in this conversation resonated with you, we'd really appreciate you sharing it with someone who might need to hear it too. Make sure to follow along so you don't miss upcoming episodes. We will be continuing these conversations and unpacking more of what care really looks like. And as always, if this is something you're going through, you're not alone. We'll see you in the next one.